All right, let's explore something truly foundational. I mean, right at the start of a new life, imagine the very first hours of a brand new foal, full of energy and promise, but then a really common yet critical challenge pops up right at the beginning. Today, we're taking a deep dive into foal meconium retention. Now, meconium, for those who might not be familiar, it's basically the newborn foal's very first poop. It's this dark, kind of sticky stuff, a sort of internal cocktail of everything that built up during gestation, cell debris, amniotic fluid, bile, all that. Normally gets passed pretty quickly, usually within the first few hours of birth, though some sources say up to maybe 9 or 12 hours is still, technically normal. But here's the really crucial part. If it doesn't all pass, it becomes retained or an impaction. And this is actually the most common cause of colic, that's abdominal pain, in newborn foals. So our mission today is to understand exactly what meconium retention is, why it's such a common thing, how vets figure it out, and importantly, the different ways it's treated. So you can be fully informed on this really vital aspect of neonatal foal health.
So just to start with the basics, we're calling retained meconium if a foal hasn't passed all of it by about 12 hours after birth. That's a pretty clear benchmark.
Yeah, and what's truly remarkable here is getting into the mechanics behind it. When that meconium doesn't pass, it essentially creates a blockage, a physical plug. Most often, this happens down low in the distal small colon, right around where the pelvis starts, the pelvic inlet. But it can also be a bit further up, like in the right dorsal or transverse colon. This obstruction then leads to, well, significant discomfort, and you get this accumulation of gas and fluid before that blockage.
And if that blockage just sits there, the consequences can stack up pretty fast.
Whoa, absolutely. This isn't just about a sore tummy. If it's not addressed, that simple colic pain and the abdominal swelling, it can lead to much more severe systemic problems. Things like hypoglycemia, that's low blood sugar release, which is a scary loss of gut movement, and dehydration. The foal's whole system can get thrown off track really quickly.
Wow. It sounds like this isn't some, super rare, unusual event then.
Far from it. Meconium impaction is the most common cause of colic in these little guys. It's definitely something every horse owner or breeder should have on their radar.
And are certain foals more likely to get it than others?
Well, while any breed can be affected, if we look at the bigger picture, there seems to be a higher incidence in colts, perhaps because they might have a slightly narrower pelvic canal. That's one theory. Also, foals born after a really long gestation, so say over 340 days, they might also be a bit predisposed. We typically see the clinical signs pop up in these neonatal foals within the first maybe 6 to 36 hours of age, although sometimes the signs can show up a bit later, even as late as 96 hours.
Okay, so it really sounds like catching it early is absolutely key here. What are those specific signs we should be looking out for?
Yeah, this is where being really observant pays off. The most common sign, like you said, is abdominal pain or colic. In a newborn foal, this can look like a few different things, maybe things you wouldn't immediately expect. They might just be restless, switching their tail a lot, or even flagging it, holding it up stiffly, kicking at their belly, pawing the ground, constantly looking back at their sides. You might also see them stretching out their legs in a funny way, almost like a rocking horse stance.
Like they're trying really hard to push something out.
Exactly. They'll often posture like they need to poop frequently, sometimes with an arch back or standing kind of camped under themselves. But, very little or nothing actually comes out. They might strain, the technical term is tenesmus, and sometimes that straining is so intense it can cause a mild rectal prolapse or even reopen the urachus, which is where urine might start dribbling from the navel again. And yeah, you might see them rolling, sometimes right onto their back, or even doing that lip curl thing, the Flumen response, which often indicates pain in horses.
Okay. What other signs point towards this specific issue?
Well, beyond the obvious pain signs, a really key indicator is just the failure to pass all the meconium. They might pass a little bit, some small dark pellets, but still have enough stuck inside to cause a real impaction. You'll also often see depression, and they might not want to nurse as much. A foal in pain might nurse less often or not as strongly, or sometimes they just nurse for comfort without actually drinking much milk. And that's really concerning because it can quickly lead to dehydration and also potentially failure of passive transfer. That's where they don't get enough of those crucial antibodies from the mare's first milk, the colostrum. You might also notice their belly starting to swell up, abdominal distension. It can become visibly larger and feel kind of firm or tight as gas and fluid build up inside. If it keeps going, you'll see lethargy, weakness. Their heart rate and breathing might get faster because of the pain, and definite signs of dehydration like sticky gums or sunken eyes. These initial signs usually show up within that 6 to 24-hour window after birth.
That is a lot for an owner to keep an eye out for. But it does raise that important question. Why does this happen? What are the underlying causes that stop things from passing normally?
Right. Well, often it's not just one thing. It can be a combination of factors. Like we mentioned, that potentially narrower pelvic canal, more common in colts, could be one piece of the puzzle. Another really significant factor is if they're slow to get enough colostrum. That first milk actually has a natural laxative effect. So if a foal doesn't nurse well early on, that can contribute to things getting stuck. Then there are systemic diseases like hypoxia, maybe a tough birth where they didn't get enough oxygen or sepsis, a bad infection. These things can slow down gut motility. And finally, just general dehydration, or if the foal is down and not moving around much, prolonged recumbency, or even certain drugs that slow down the GI tract can play a role.
Okay, so an owner has spotted these signs, they're worried. What happens next? How do veterinarians actually confirm it's meconium retention and, just as vital, make sure it's not something else?
Yeah, connecting the dots starts with a really thorough physical exam and just watching the foal. The vet will look at the foal's overall attitude, check for all those colic signs we just talked about, feel the abdomen, note its size. They'll also be looking carefully for any fecal staining on the hind legs or bedding. That can tell you some meconium passed, but maybe not all of it.
And I guess a digital rectal exam is pretty standard.
Oh, absolutely. It's a primary diagnostic tool. A gloved, well-lubricated finger can often feel a firm lump of meconium, especially if the blockage is low down, like in the rectum or that bit of small colon near the pelvis. It's important to remember, though, just because you can't feel anything doesn't completely rule it out. The impaction could be higher up. Careful, deep palpation of the abdomen can sometimes reveal firm meconium in other spots, like the dorsal or transverse colon. They'll also check the umbilical area carefully, looking for that patent uricus, the urine dribbling, or any signs suggesting a bladder rupture, which can happen from all that straining. And when they listen to the abdomen with a stethoscope, the gut sounds might be reduced or even totally absent. Usually the rectal temperature is normal unless a secondary infection like sepsis starts to set in. Beyond just the hands-on exam, imaging is incredibly helpful. Abdominal ultrasound, for example, is great for actually seeing the retained meconium. It usually shows up as bright, hyperechoic, or maybe mixed echogenicity stuff inside a colon that's stretched out with gas or fluid. Ultrasound is also invaluable for ruling out other nasty things that might look similar initially, like Atresia coli, which is a birth defect where the colon isn't fully formed, or an intestinal volvulus, a twisted gut, or even a ruptured bladder. Abdominal x-rays, radiography, can show sort of granular-looking contents in the colon and, again, signs of gas and fluid building up before the blockage. Sometimes they might do contrast radiography using a barium enema. That can give even more detail about blockages, and, bonus, the barium itself can sometimes help soften the impaction.
What about blood tests? Do they play a role here?
They do, though often the basic blood work is pretty normal in straightforward cases. A complete blood count, the CBC, and serum chemistry are usually run. These might show changes linked to stress, like high white blood cells or high blood sugar, hyperglycemia. Or if the foal's dehydrated, you might see elevations in the PCV, the packed cell volume, and total protein. Blood lactate and glucose levels might also be monitored to get a sense of the foal's overall metabolic state. And crucially, checking IgG levels, immunoglobulin G, is really important. This tells us if the foal got enough antibodies from the colostrum. It's a measure of passive transfer, especially vital if nursing has been poor.
That makes total sense. And because these signs can look like other problems, ruling those out is critical. What are some of the main things the vet needs to differentiate this from?
Absolutely, the vet really has to put on their detective hat. Conditions like Atresia coli can look very similar at first, but a key difference is that with Atresia coli, you won't see any meconium staining, even after giving enemas, because there's usually a complete blockage from birth. Intestinal ganglionosis, sometimes known as lethal white foal syndrome, seen in specific genetic lines like white foals from Ovaropaea. Paint parents is another one. These foals typically produce no meconium at all. Then you have other gut issues that cause colic in newborns, like enterocolitis, which is inflammation of the intestines, or a small intestinal volvulus, that twist, or an intussusception, where the bowel telescopes on itself. All possibilities. And finally, uroperitoneum, a bladder rupture, can also make a foal posture and strain in a similar way. But finding free fluid in the abdomen and seeing specific electrolyte changes in the blood helps point towards that instead.
Okay, so once the diagnosis is confirmed as meconium retention, the goal is clear. Get that stuff moving, ease the pain, and provide supportive care. And the good news, you said, is that most cases respond really well to medical treatment.
Yeah, what's fascinating here is just how effective those initial non-invasive options usually are. Enemas are really the go-to first-line therapy. Vets often start with warm, soapy water enemas, using appropriate amounts, maybe 200 to 300 milliliters, sometimes up to a liter in bigger foals, delivered gently through a soft tube like a red rubber catheter or a Foley catheter, inserted just a few centimeters into the rectum.
And you mentioned commercial enemas too, like the ones people might use.
Yes, those commercial sodium phosphate enemas, like the Fleeper brand, are commonly used and they're often quite effective, especially for those low impactions. However, you do need to be a bit careful with them. Repeated use can irritate the rectum, and there's a risk of causing high phosphate levels in the blood, hyperphosphatemia, which can actually be dangerous for foals. So judicious use is key. Now, for impactions that are a bit more stubborn and don't respond to those simpler enemas, a 4% acetylcysteine solution retention enema can be highly effective. Acetylcysteine is a mucolytic. What that means is it actually breaks down the sticky bonds, the disulfide bonds, within the meconium itself, making it less thick and much easier to pass. This solution is given via a Foley catheter, which has a little balloon cuff that's inflated gently to help keep the solution inside, usually for about 15 to 45 minutes. Sedation, often with drugs like butorphanol, maybe diazepam or xylazine, is usually necessary for this procedure. It helps minimize straining and make sure the solution stays put to do its job. And this can be repeated in 12 to 24 hours if needed.
Okay, so beyond enemas, what about things given by mouth?
Oral laxatives can definitely play a role too, especially once the foal is a little older, generally over 24 hours. Mineral oil can be given through a nasogastric tube, that little tube through the nose down to the stomach. But as I said, you need to be a bit cautious with very young foals under 24 hours as it might interfere with absorbing that vital colostrum. Magnesium hydroxide, which most people know as milk of magnesia, is another option. And something that's becoming more common and seems quite safe and effective is polyethylene glycol, or PEG. Often used for more stubborn or chronic cases, it's an osmotic laxative, meaning it works by drawing water into the intestine, which helps soften the stool and encourages it to move along.
And obviously, managing the pain is huge for these uncomfortable little ones.
Oh, absolutely. Pain management is paramount. NSAIDs, non-steroidal anti-inflammatory drugs like flunixin, meglumine, banamine, or ketoprofen can be used for pain relief, though you always have to be careful using NSAIDs in neonates, especially if they're dehydrated or there's any concern about their kidneys. Often, but torphanol tartrate is preferred for pain control, particularly in foals less than 24 hours old. It provides good pain relief with maybe fewer systemic concerns than NSAIDs in these tiny patients. And of course, like we touched on, sedation is often needed for procedures like the acetylcysteine enema, just to keep the foal calm, comfortable, and cooperative.
What about just general supportive care around all this?
That's absolutely critical. The whole picture matters. The veterinary team will encourage adequate nursing, ideally every hour if the foal seems up to it. If nursing is poor, then supplemental feeding is essential. Using the mare's milk if possible, or a good quality milk replacer given by bottle or sometimes via that nasogastric tube, starting with small amounts frequently. And it's so vital to check those IgG levels to make sure passive transfer was successful. If it wasn't, if the levels are low, a plasma transfusion might be necessary to give the foal those needed antibodies and protect them from infection. Intravenous fluids are almost always a cornerstone of treatment. They're crucial for hydration, correcting electrolyte imbalances, and often have dextrose added for energy. Systemic antibiotics might be started if there's any worry about sepsis, maybe if the foal seems really sick or if the gut barrier might be compromised. And if the abdomen is really distended with gas, passing a nasogastric tube can help relieve that pressure, which can make the foal much more comfortable.
So let's look at the big picture for those really tough cases. You said medical management usually works, but I guess there are times when it's just not enough.
Yes, and this raises that important question. When do we need to think about surgery? Thankfully, it's very rarely necessary for meconium impaction. It's really considered a last resort only when aggressive medical therapy like those acetylcysteine enemas and supportive care has failed to resolve the blockage.
What are the signs that might push things towards surgery?
Well, persistent, severe pain that just isn't responding to the analgesics, the pain relievers, that's a major red flag. Also, progressive abdominal distension, the belly just keeps getting bigger despite treatment. Any signs that the foal is deteriorating, like a persistently high heart rate, signs of shock, or if there's evidence from ultrasound or other diagnostics that the bowel itself might be compromised, maybe losing its blood supply, those are strong indicators. What surgery typically involves is a ventral midline coleotomy, basically, an incision along the belly. Sometimes, once inside, the surgeon can manually break down the impaction with the help of an enema given on the table and by gently massaging the bowel. In very severe or stubborn cases, they might need to perform an enterotomy, which means making a small cut directly into the intestine to physically remove the meconium or whatever is causing the blockage.
All right, let's unpack this final part. Once a foal has gone through this, what's the long-term outlook? And maybe more importantly, what can be done proactively to try and prevent it in the first place?
Yeah, looking at the broader implications, the prognosis for straightforward meconium impactions that respond to medical treatment is generally very good to excellent. Often, just one or two simple enemas will resolve the mild cases pretty quickly. The prognosis for cases that end up needing surgery is still considered fair, but there is a higher risk of complications down the road. Things like abdominal adhesions, where tissues inside the abdomen stick together.
Okay, so prevention. What can owners or breeders do?
Well, ensuring that foal gets adequate colostrum intake right away is paramount. Remember that first milk provides not only immunity, but also that natural laxative effect. Now, when it comes to specific preventative measures like enemas, there are kind of different schools of thought out there. Some veterinarians and many breeding farms do routinely administer a warm, soapy water enema if a foal hasn't clearly passed a good amount of meconium within, say, the first 3 hours of birth. Some farms will even routinely give a prophylactic fleet enema or a soapy water enema to all newborn foals, especially colts or foals born after a long gestation, within those first few hours as a preventative measure.
So, some jump right in proactively, others tend to wait and see. What's the thinking behind waiting if enemas can be helpful?
That's a really good question, and it comes down to balancing the potential benefits against any small risks. While often helpful, giving an enema to every single foal, whether they strictly need it or not, does carry a very small risk of causing some rectal irritation, which could lead to more straining. Or, in really rare instances, if not done carefully, maybe even causing a small rectal tear. So some practitioners prefer to wait and watch closely for actual signs of retention straining, discomfort, lack of feces before intervening. They feel the foal's natural processes should be given a chance first, if possible. Ultimately, no matter which approach a farm takes, close observation is absolutely key. Constantly monitoring for the passage of that first meconium, knowing what normal neonatal feces look like afterwards, and being quick to notice any decrease in nursing, any lethargy, or any signs of discomfort should always prompt a call to the veterinarian for an examination.
And are there any other potential complications beyond the immediate ones that people should be aware of?
Yeah, just a few things to keep in mind. Beyond that risk of rectal irritation or tears from maybe too many or too forceful enemas, there's a slight possibility of secondary ileus. That means the gut might slow down again even after the initial impaction is cleared. There's also a theoretical risk of bacterial translocation bacteria moving across the gut wall and potentially causing sepsis if the intestinal lining gets really irritated or damaged. And of course, as we mentioned, abdominal lesions are a potential long-term complication if surgery ends up being necessary. It just highlights how interconnected everything is in there and why that early, careful intervention is so important.
So what's the big takeaway from all of this discussion? We've sort of journeyed through these really critical first hours of a foal's life, looking at a common but thankfully usually manageable challenge. I think the key message is understanding those signs, knowing what to look for, and realizing that early intervention, often with pretty simple treatments, is absolutely key to getting a positive outcome. It really highlights that delicate balance of health in a newborn and just how important attentive, knowledgeable care is during that crucial initial period. Here's something to think about. What other seemingly minor physiological events, maybe in young animals or even in human infants, might have really profound but easily preventable consequences if they're not understood and addressed quickly? What simple observation, perhaps something easily overlooked, could truly make all the difference in the path a new life takes?